Hello, this is Mark Lynn from Healthcare Business Specialist in Chattanooga, Tennessee, and this is the Telehealth Medicare Part A billing per SE 20016 webinar. This is the pop-up version of the webinar where I'm going to add a little bit more detail to the webinar we did on April the 22nd that I had to do sort of a abbreviated session. And since we have no speakers on this one except for me, we have a little bit more time, and I'm really just going to focus on the Medicare Part A RHC piece for you guys. Here is my contact information. I'm a CPA from Chattanooga, Tennessee, and have worked with the Rural Health Clinic program for the past 35 years or so. So if you're not a member of our Facebook group, please become a member. We're over 1,500 members now. There's a lot of great information on the website and a lot of interactivity. Excuse me. What do we do? Healthcare business specialists. We work on Medicare cost reports. We prepare about 175 of those for independent RHCs. We do program evaluations, RHC startups or conversions, emergency preparedness. In Tennessee, we do a lot of the TennCare quarterly reports for our clients. And if you want to find out more about our services, there's a Google Doc that you can go to, and there's an RHC cost report brochure as well. For all of the resources related to this presentation or just about anything we do, we will place them on our COVID-19 website. We try to keep that updated just about every single day. We will put recordings, we'll put YouTube videos on there of this session and the other webinars that we do. So if you'll check that on a daily basis, you'll find a lot of new content just about every day. Disclaimer, everything is changing extremely fast due to COVID-19. And so some of the information may be outdated. If I do have outdated information on there, especially government documents tend to be outdated. Try to look at anything, make sure you get a timestamp on anything that you look at, because looking at documents now, I see so many documents that have incorrect information on them. So you want to make sure that everything is time stamped so that you know that it is current, because some information can be days old and be out of date. So hopefully we'll have everything current, but there's no guarantee in the times that we're in. So let's go ahead and get started. This is Medicare Part A RHC Telehealth Billing. And telehealth, the difference between, people ask us all the time about what the difference between telehealth and telemedicine. In general, telehealth is a more general term that includes both clinical and non-clinical services, while telemedicine refers mainly to the provision of clinical or medical services. Think HCPCS codes. Unfortunately, Medicare gets it completely backwards. They use telemedicine as a broad term, and telehealth is very, very, very specific in Medicare language. So not only is Medicare falling behind in the language, it is falling behind in access to care, just because of the rules with Medicare was that you until the PHE came along, and you'll hear me say PHE all the time, and that stands for public health emergency. As long as we're in the COVID-19 public health emergency, which was dated, I think it's March the 1st, goes back to March the 1st of this year, then some of these rules will apply. So the first one that we're talking about was a patient must be located at a specific or originating site. That went away on March the 6th. And before, you had to come to a rural health clinic, to a hospital, to a nursing home, someplace where there was on a official list of originating sites to even start a telehealth visit. You couldn't be in your home. That changed on March the 6th, so that was great. Also, you had to be in a rural area that was underserved. You couldn't be in an urban area. So people in New York City could not do telehealth. That changed on March the 6th as well. RHCs could not be a distant site. That means they couldn't be the physician who is in New York City doing they can be the physician while your patient could be in rural Tennessee, take it somewhere. That RHCs couldn't be that distant site, maybe specialist that was located in an urban area. Also, and this still continues to this day, is the telehealth costs are not used to compute the all-inclusive rate. You have to pull that cost out of your cost report. We don't count the telehealth visits, so make sure you keep up with those. Make sure you keep up with your cost during this period of the PHE as well. So when we do prepare your cost reports at the end of the year, we will have all the information that we need to do that. So if you have any questions, contact me if we're preparing your cost report. If we're not doing them, then contact your cost report preparer on what information they will need. I told you this earlier, originating sites for telemedicine can now be in urban areas and can be initiated from the patient's home effective March the 6th, 2020 during the period of the PHE. Hopefully, we can only pray that this will continue after the PHE, because this is truly where healthcare has been going for a long time now, and now Medicare is forced to get on board. And we're going to talk about Medicare Part A telehealth billing for the most part today. We will not try to hide our resources. We put together an Excel spreadsheet that right now has about 75 different documents on it. I've got about 25 to add, so it'll have 100 documents. It's sortable, so you can find the information that you need very quickly. So it's very helpful. This is complicated. The laws, regulations, and guides are changing daily, almost hourly. I just got a couple emails this today where the accelerated payment program from Medicare has been shut down, and so there's a lot of moving parts now. It's hard to keep up with them, and there's a lot of conflicting effective dates for things. So you're not sure which one to use. One of the big things that happened was this CARES Act, what we typically call it Phase 3 of the Emergency Stimulus Act. That was approved on March the 27th, 2020. And Section 3704 is really helpful to rural health clinics because it allows them to be distance site. Up until this point, we've had several people, some people said, yes, we could be a distance site. When the president made an announcement on March the 17th that all areas would be covered by a rural health clinic, with telemedicine, and all providers could provide that. That was enough for some people to say, oh, great, rural health clinics can be distant site. Other people said, no, we need to see it in regulation because it is a regulatory standard. And that's probably what most of the people went with. But now, March 27th, that regulatory piece is in the law, so we can feel very comfortable in being a distant site. CMS was going to develop a plan to pay based upon Medicare Part B average rates. That took a lot longer than we ever dreamed it would, and so and we'll talk about that in the next slides. And then also, again, RHC, the telehealth costs are not allowable on the cost report in computing your all-inclusive rate. And the time frame, and this is good until the end of the state of national emergency, the PHE. And then there's the document that you can get your hands on worth $2.2 trillion. As soon as CMS released that rule on March 27th, or the feds released that rule on March 27th, CMS came out with the rule called an interim final rule, and it added about 85 new telehealth codes that physicians and providers can be performing as well. That came out 3 days after the March 27th regulation, and this was finalized on April the 6th, the final version of this. So here is the new listing of the 191 different codes, telehealth codes that have been added. They look like this. It's an Excel spreadsheet, so don't freak out when you click that button and nothing really happens. It's basically downloading an Excel spreadsheet to your computer. So here's the listing. Notice there's a temporary addition. There's 85 temporary codes that are listed here that are only good during the PHE. So be careful once it's over not to use those. there's 5 different types of telemedicine. I only have 4 boxes on here because we didn't have room for remote monitoring, but remote monitoring is very easy for rural health clinics. It's not allowed, or it's not reimbursable in the RHC setting. So that one is very simple. The first box over here is telehealth. Telehealth has to be both audio and visual, so you can't have a telephone only call. And that's a big problem. I know we've got clinics in West Virginia, and there's those mountains, it's almost impossible to get good audio and video on your cell phone. Believe me, I've driven through it many times, and there's no cell phone or no video in that area for sure. So that's a big problem for us. If you go over on the yellow box over here on the side there, you can see that telephone is not an RHC covered service, and the interim final rule added telephone services. You see 99441 and 99 through 99443. Those CPT codes were added during from the interim final rule for telephone only. RHCs as of right now cannot do that. They may be able to. I've heard some people say, well, why don't we just bill them as a G0071, which is a virtual visit. That's that orange section there. So that might be an answer as well. We'll have to talk about that one a little bit more. But telehealth, again, expanded to all areas. So you don't have to be rural or urban. You can be anywhere, and you can do telehealth. You can also be for new and established patients during the PHE. They're waiving that. Before, it could only be for established patients. So keep that in mind. Copays and deductibles will apply, but you have some flexibility to not try to collect those during this time of PHE. Office Inspector General will be sort of what they say, having a blind eye to people that waive the copays and deductibles during this period of time. You will get $92 for telehealth visits in rural health clinics, whether you're provider-based or independent. Consent to treat is still required. You can get that verbally. You can get that done incident to, which means your nurses can get the consent to treat. It doesn't have to be under direct supervision of the physician, nurse practitioner, or PA to get that consent to treat. So this is the great thing that was added on this March 27th CARES Act. Virtual check-ins, this has been around since January of 2019. Basically, it can be 2 things. Number 1, it can be a very quick phone call, or number 2, it can be a store and forward type of communication with a provider, where maybe you take a picture, maybe you have some type of equipment that will monitor. Think of an X-ray. You can send an X-ray and to the physician, and they can look at it and make a medical decision based upon that. So that would include store and forward technology. So for virtual check-ins, no geographic restrictions there. They can be new patients during the PHE as well. Same rules on code. I won't go over each one of these codes of the rules, because most of these rules are the same about copays and consent to treat. Here are the codes, the Part B codes. G0012, that is the code that is for basically a 5 to 10 minute phone call. And the G0010, that is for something that's store and forward, where you send it to the physician. Maybe they look at a picture of a ward or a cut or something and tell you whether to come in or not. We'll talk more about that as we get along. But right now, the payment has increased to $24.76 for those. Used to be $13.69 last year, and that's dropped to $13.53 this year. And that changed March the 1st of this year to go up to $24.76. And the reason why it changed was because CMS added e-visits to the calculation here. And those are a patient portal. So in this case, a patient enters a secure patient portal and asks the physician, nurse practitioner, and PA questions. and that physician, nurse practitioner, PA keeps up with their time and responds to them through that portal. And once you get to a certain number of minutes, then you can charge that as this 99421 up through a 99423. And there's three levels of minutes that CMS will continue to pay higher and higher rates for the number of minutes. As a rural health clinic, once you get to the minimum number of minutes, everything is going to be a G0071. So it doesn't matter if you've worked 5 minutes, 10 minutes, 20 minutes, or over 30 minutes, you're still going to get the same amount. And so the payment is that same $24.76. So remember, these codes are time-based, so time stamp your records and keep up with your time over a 7-day period of time. 7 days is the magic time frame for Medicare when it comes to these sort of timekeeping rules there. Of course, telephone, we sort of mentioned that. These are prolonged phone calls. They can be between, I think there's from like 5 to 10 minutes, and I think we have a listing of them somewhere where they're 10 to 20 and maybe up to 30 minutes. There's 3 different codes, and CMS pays differently for each one of those. But as of right now, that is not an RHC service that you can do a telephone only call. Like I said, some people say, well, can we convert this into a virtual check-in? I have that question raised to CMS right now. I haven't got the answer yet. My recommendation is hold those codes and hope that CMS makes a change, because CMS is contemplating changing the guidance that we've received so far. And of course, this webinar will be out of date whenever they do that. But that's sort of the way things have been going. Here's a slide that just talks about the 2 different types of communication. There's synchronous. To be a telehealth visit, it has to be synchronous. That means you have to have video and audio, and it has to be synced in that you can see that person, you can talk to that person, you can communicate with them. And then asynchronous means that it's not synced. It means that there's things like file sharing, things like sending somebody an audio clip, a picture. Those sort of things are asynchronous, and what we typically call them is store and forward type of technology. And there's certain rules for that, but your telehealth rules are the synchronous ones. Those are the ones that we're most interested in. It took 31 days for CMS to come up with a plan to pay rural health clinics after March the 27th. The actual rules were published on April the 17th, 2020. It was a 4-pager. It was under MedLearn Matters SE 20016. And really, it was only about maybe a little over a page of actual guidance for rural health clinics. So there wasn't a whole lot in this document. There's the link for you guys to get it. What's confusing is CMS has invented a time portal where they can actually go back in time. I don't know if they use a DeLorean or not, but they backdated the guidance from to January the 27th, 2020. Even though the CARES Act was approved March the 27th, allowing RHCs to be distant site providers, and 39 days before patient homes were allowed as originating sites on March the 6th. Now, which one of those dates supersedes the others? That's a question for somebody with a higher pay grade than me, but it is quite inconsistent what these regulations say. Most of the RHC community is using January 27, 2020 as the date that they're going to go back to. What we did was we put together a FAQ, and let's see here, an FAQ for you guys. It's an 8-pager. And it's got a table in it that sort of defines all the different services. And it has 25 different frequently asked questions that a lot of people have. And we've summarized some of the same things that were in the table that I just showed you. So I won't go through this in detail. Otherwise, this webinar will end up being very, very long. But this table will be very, very helpful to you. It's the last page of the FAQ. That we've got for you. And then One of the great things is CMS has been very, very transparent. Every Tuesday and Thursday at 5 p.m. Eastern, you can get into something called office hours and ask them questions. What I would recommend is about 20 minutes before the phone call in, get on the line, and then hit *1. That's how you get in the queue to ask questions. If you don't get in 15, 20 minutes ahead and hit *1, you're not going to get a question in during that hour. And then there is the FAQ that I talked about there. That's the 25 questions and that table where you guys can find that. One of the things that's very hard about the FAQs is things have changed, and this is from our document here. And because we get this question all the time, can a physician, nurse practitioner, PA actually work from their home and do telemedicine from their home? And the answer is yes, as long as it's during rural health clinic time. So you want to think about that. If you're planning on doing RHC telehealth visits from your home at 6 p.m. at night, you probably need to change your RHC hours to include that time and compensate yourself for that time when you're working from home. So have sort of standardized hours where you're doing that. Obviously, if it's happening during your normal RHC hours, it's not a problem. But I just want to keep that in mind, that the rule says it has to be done during RHC hours, but you can do that at home. I think on March the 22nd, we were getting the question and there was an FAQ from Medicare that was released with a question 11 on it that said if you have a patient, if they have a physician who's working from home, do they have to call in to Medicare Part B and give them the home address and include that home address on box 32 of the 1500 form? And the answer was yes at that time. About a few days later, CMS came off of that and they removed that FAQ from the document, from their documents. So you do not have to do that. I think I told a lot of people at the time that they had to, and then a few days later, CMS said, no, we've tabled that. You don't no longer have to do that. So again, these rules are very fluid. I can tell you something that was true for today, and it's going to be completely wrong tomorrow. So how will RHCs get paid? One thing is, we're going to get $92 per telehealth visit. If you're an independent RHC, you're probably, clapping and happy. And if you're a provider-based RHC with a national average rate of $214, you're pretty bummed out about that, because you're not getting your all-inclusive rate for these services. Now, for a period of time, you are going to get that all-inclusive rate. You're going to be very happy about it, but CMS is going to recoup that money from the provider-based down in the future. So notice these dates here: January 27, 2020 to June 30, 2020. The problem is CMS has a very old, outdated computer system, and they're only making a change to it on July 1st is the next time they have a chance to change the system. So until that date, rural health clinic telehealth claims are going to have to include the 95 modifier, and you're also going to have to include the CG modifier, and you'll get different answers from CMS. They say, well, there's no reason to put a CG modifier, but believe me, you do. Just because you're dealing with an old, outdated system, it's not logical. Again, we tell people all the time, never use logic when you're dealing with Medicare rules. It's mainly a rote process of memorization. And right now, you need to remember to use the CG modifier until June the 30th with your telehealth claims, and use the 95 modifier. That will go away when CMS updates their system, but until that date, you are going to be paid a little bit differently. You're going to include the HCPCS code from that listing of 191 telehealth codes, and you're going to put the CG modifier, and you're going to put the 95 modifier as well until that point. So let's go into some of the details of this here, and this will be very helpful. How to bill Medicare telehealth from January 27th through June the 30th. Just a little reminder here. Number one, you're going to put them on the UBO4. format. That's an ANSI 837I. That stands for institutional. So you can use a UB04. The bill type will be the bill type you use 99% of the time, a 0711. Your revenue code will be the 52X. If it was normally, if this telehealth service was normally done in the office, but a 0521. If it's something that would have normally be done in maybe an assisted living facility, that will be the patient's home, that's going to be a 0522. If it's done in a skilled nursing home that's paid for through the Medicare Part A trust fund, that's going to be a revenue code 0524. Or if it's done in a nursing home that's not paid for through the Medicare Part A, that 100 lifetime days of skilled care, that's going to be a revenue code 0525. So depending on the location of the patient or where they would normally be, that's where you get the revenue code. The HCPCS code, that's going to be from that listing of 191 different telehealth codes. So you'll use that code, for example, a 992213. And then finally, you're going to add this 95 and the CG modifier. And also to confuse things, they have added a CS modifier as well. If you need to add a CS modifier, you can do that as well. We'll talk about CS in a minute, so I won't bore you with that and then have to repeat it again. No place of service on the UB04. We get this a lot. People asking, what's a place of service? What's a place of service? There is no place of service. The place of service is your revenue code. Okay, and we can celebrate on July the 1st because the new G code will be here. Starting July 1st, the CMS computer is going to be reprogrammed. At that point, you're just going to have to put the G0025 if you do one of those 191 telehealth services starting July 1, 2020. And CMS will pay you the correct rate. There'll be no recoupments and no reprocessing of the claims at that point. So you'll get your $92 rate at that time. So that will be hallelujah. So here's how we would bill Medicare for the G0025 on or after July the 1st, 2020. Same form, UB04, same bill type, 0711, same revenue code. And the only difference now is we're going to put the HCPCS code of G0025. You do not have to add the modifiers, the CG. You don't have to add the 95 modifier. If you do need to add the CS modifier, then you can do that. And your payment will be $92. We're going to go through several slides that have some tables, basically a snapshot of a UB04, and I've got some T accounts on here, but we're going to have to make some assumptions. So our first assumption is we're going to charge $100 for a 99213. That may or may not be reasonable for your area, or if you're provider-based versus independent, but the math is very simple on $100. The all-inclusive rate, if you're an independent RHC, you are capped at $86.31. Some of the MACs will pay you more than $86.31, but we're just going to assume that you're at the capped rate for core services. So your math may be a little off. I've seen independent RHCs with capped rates, with interim rates of $100 a visit, $95 a visit or so. But we're going to use $86.31. If you're provider-based, the average rate is about $214 for your all-inclusive rate or your interim rate. And so we'll use that $214, but your rate will be all over the board. Some of them could be very low, $75, $80, $90, $100. Some of them could be $250, $300 per visit. So look at your particular rate to see how this affects you as well. And then we're going to use the same telehealth rate, $92 for both independent and provider-based. The copay will remain the same. It's going to be $20 whether you're independent or provider-based. That's 20% of 100. And then we'll go over on this side, the settlement calculation. We're going to assume that Medicare is going to pay us 80%. And the one thing that we don't really talk a whole lot is the sequestration has stopped during the PHE. That's that 2% that Medicare would take away from you from your rate. Remember, you'd always do your calculation and it would be off by about 2%. That 2% was sequestration. That is no longer in effect during the PHE. So we would get the full 80% of our 8631. So we would get $69.05 as an independent RHC, and Medicare would pay you $171.20 as a provider based if your rate was $214. And so your telehealth reimbursement rate is $73.60 for an independent. That's 80% of $92. Same rule applies to provider base. You're both going to get the same exact amount for a telehealth service. If you're an independent, you're like, oh, this is great. I'm going to get an additional $4.55 whenever CMS reprocesses these claims in July 2020. If you're a provider-based RHC, you know, oh goodness, you're gonna have to pay back almost $100 per telehealth visit. So you need to think about that. It's how are you going to deal with having to pay back that $97.60 or whatever your amount adds up to. Some people have said, well, we'll just wait and start billing on July 1st, and you can do that. There's timely filing issues that you need to worry about, but the Medicare timely filing issue is 1 year. So unless there's secondary issues that you have on billing timely, you could hold those claims at that point. Or what you may want to do is get an interest-free loan from the federal government up at that point and bill these now, build up a little nest egg, and remember you have to pay that back or it is going to get recouped in July. So let's go into our screenshots of our UB04. Here's field locator 42. This is revenue. You're going to use revenue code 0521. In this case, we have an established office visit, a 99213 that is on the listing of the 191 telehealth codes. We're going to add that CG and that 95 modifier. Our data service is going to be January 1, 2020, the first day that we could do this. And our charge is $100. Our rate is $86.31. That's not on your UB04, but I'm just putting it there to remind us what our rate is going to be. Here's our old simple T accounts, just to do very, very simple debits and credits here. When we charge this patient, we're going to have a credit of $100. We're going to debit account receivable and that. And then once the money's come in, we're going to have a receivable. They're going to pay us $20 for the copay. So the patient's going to pay us 20% of our charge of the $100. Medicare is going to pay us 80% of $86.31 at our all-inclusive rate, and we're going to get paid $69.05. And then our contractual adjustment in this case is $10.95. We're going to write that amount off as being unpayable. And remember, you cannot balance bill this patient. You cannot collect this $10.95. You have to write that off. So we balance here 100 and 100. Well, what happens when CMS reprocesses this claim in July? They're going to reprocess it at $92. We are going to get a check for $4.55 per telehealth visit, and we're going to have a negative contractual adjustment at this point, so that we end up basically netting out to where we collect about $94 or so on every telehealth claim in this example. And so how we came up with our math, and this is the independent RHC. Can't remember if I said that at the beginning, and this is for the period of time, January 27th, 2020 through June the 30th. So it's for this specific period of time. So how did I come up with my math on the $73.60? I just took $92 and multiplied that by 80%, and that's how much our Medicare telehealth payment is going to be. Subtract out what Medicare paid us, the $69.05. That gives us $4.55 owed to us from Medicare when they reprocess the claim. Okay, let's move to provider-based RHC. And everything is pretty much, it's exactly the same on our UB04. The only difference is when we get our first check in at our all-inclusive rate, we're going to get $171.20. And this beautiful thing called negative contractual adjustment happens where you actually receive more money than you charged. In rural health clinics, there's no such thing as what's called lesser or cost of charges. So in this case, you actually can collect more money than you receive. Just have fun trying to explain that to your patients when they get their Medicare summary notice each quarter. So if you're provider based, your charge will probably be much closer to your actual, much higher charge because of the way that works. In this case here, whenever the claims are reprocessed in July 2020 at $92, here's the bad news: is Medicare is going to withhold cash from you of $97.60, and your contractual adjustment is going to be a debit, a bad one of $97.60. So what happens when this thing normalizes is you end up exactly in the same place as the independent RHC. You have a $100 charge, and you're going to have about a $6 contractual adjustment, and you're going to end up collecting roughly $94, exactly the same thing as your independent RHCs do. So this is one reason why the National Association of Health Clinics fought so hard to get the all-inclusive rate in here, because this is so damaging to our provider-based RHCs, which depend on these monies to support our rural hospital infrastructure system. And this is really going to hurt our provider-based RHCs. Okay, and so what happens if we have a COVID-19 patient? There's something called the CS modifier, and again, we'll talk a little bit more about that at the very end of the presentation. But for right now, what we need to know is if you put the CS modifier on there, then the copays, you do not have to collect copays from the patient, and Medicare will pay you your all-inclusive rate. You won't get 80%, you'll get the full amount of money from them. So in this case, our form in field locator 44, our HCPCS code is going to be 99213. We'll put the CG modifier, the 95 modifier, and the CS modifier. And you can see when CMS reprocesses the claim at $92, we are going to get some additional $5.69 for those claims as well. So that's the CS modifier. Glory hallelujah, we finally made it to July 1st, 2020, when there's going to be no reprocessing. And in this case, what we're going to do is from July 1st, 2020 until the end of the PHE, your UB04 is going to look like this. You're going to get a G0025. It's going to go in field locator 44. Our charge is going to be the same. Our payment rate will be the $92 for telehealth there. So your copay will be the same, the $20. You'll collect that. You're going to collect $73.60 from Medicare. And your contractual adjustment, what you're going to run off, will be $6.40 in this example. So that's going to be so clean and so simple when we get there. And if you have a nurse-only visit, there is some provisions for a nurse-only visit, a 99211. We showed you the example of that. I would not do that yet. I've got a question into CMS about whether we can really do that or not. So I would hold off on that until we know for sure whether CMS really meant for RHCs, because we've always had that rule where you had face-to-face encounter between a physician, nurse practitioner, and a PA, where a medically necessary service was provided within the scope of practice for that provider. And this gives all of us RHC longtime folks the heebie-jeebies trying to do that. So we want to get some clarification if we really can do that. So let's move on to the next one. What if we do services in the nursing home from July 1 through the end of the PHE? Again, same, here's your revenue code, 0525. This is in a intermediate care facility, not skilled. G0025 is our HCPCS code we're going to use, and CMS is going to pay us $92 if we do nursing home rounds via telehealth as well. So, and again, you get the same amount of money, your contractual adjustment is the same, so it works very, very well for everybody. Okay, Virtual visits have been around since January 1, 2019. And then here is the information on that. Here's a great FAQ for those. We'll talk about some of these timeframes. I've got a slide for that in a minute. So let's go and look at this. And a little word of caution on the FAQs, they are a little bit outdated. So you want to be careful. If something doesn't sound right, it may not be correct. Here is something that Patty Harper put together from InquaSeek, and we certainly do appreciate all that she does for rural health clinics on the National Association of Rural Health Clinics level, on their listserv, which we recommend you joining the National Association of Rural Health Clinics listserv, and join our Facebook group. Well, like I said, we have about 1,500 members, and Patty is great about answering questions. So she put together this changed for virtual services. They actually added these 99421s and 99422s and 99423s sometimes in March, and they added that to the G0071, and that increased the reimbursement. So we have a code, we have a couple of slides that show this. So before March the 1st, 2020, if you did a G0010, which is basically storing forward, that's evaluating of a video or an image, and then you responded back to that patient within 24 hours, and that took between 5 and 10 minutes. Through Part B, you get paid $12.24. And if somebody called you up and you talked between 5 and 10 minutes and you documented your time, then on the Part B side, they paid you $14.80. What on the RHC side was they basically just averaged these two, give you a G0071 and paid you $13.69 last year. And that's a 2019 rate. In 2020, they changed the rate they actually dropped the rate to $13.53. So this was before March the 1st. You did not have any, you used revenue code 0521 for this. That has been a huge problem recently because the MACs have been saying that's the wrong revenue code. The MACs are wrong. It is the correct code. They are actually getting their systems corrected right now. As we speak, you guys have been getting denials. So I would hold off on billing any more G0071s for the next week or two until the MACs get their systems going correctly. No CG modifier is required for this. And these codes are for up to 7 days of accumulative time. So keep up with your time. All these telehealth codes are basically time-based. So you should timestamp everything so you can prove to Medicare how much time you've spent providing services. This is the new 99421, 99422, and 94223 portals. You can see that and this is basically a portal where you have a secure portal. The patient goes in and they're asking you a question and you're responding to that through the portal, basically sort of like an email to that patient. Keep up with your time that you spent responding to these patients. And once you hit 5 minutes, then you're going to have a G0071 in a rural health clinic, and you can bill $24.76. If you were Part B, you keep up your time for these seven days, and then if you hit 21 minutes, you would get paid $50.16. That doesn't really apply to rural health clinics, because once you hit your amount of time, you're going to hit the G0071 and get your $24.76. And there's the regulations that made that available. Here is the timeline. If we have a virtual visit today, right now is my virtual visit day. What happens is if it relates to a visit that occurred within the previous 7 days, then your provider cannot charge that virtual visit. So you're going to look back 7 days. If it's following up something that occurred, a visit occurred within 7 days, then it's not a virtual visit. Also, if I call you and have, I don't know, a wart or something like that, and I show you a picture of it and we talk on the phone about it, and you say, oh, Mark, that looks really angry, come in first thing in the morning, that's not a virtual visit either, because if you go, you can see here where it says the medical discussion or remote evaluation does not lead to an RHC visit within the next 24 hours or the soonest available appointment. So if you get the soonest available appointment after this virtual visit, you can't charge for that. You're going to charge for the office visit that occurs on the next day or the next available appointment. So how do you bill for the G0071? UB04, ANSI 837I institutional bill type 0711. Revenue code is correct, 0521. HCPCS code, you can put that in field locator 44. It's going to be G0071. And during the period of the PHE, your payment is going to be $24.76. And in here is what the field locators look like on the claim. And if you do this from March 1st till the end of the PHE, there's your $24.76. Notice you don't have to put the CR or the DR modifier on any of these claims for RHC. CR it typically means catastrophic or disaster related. Those are not required, is the guidance from CMS. Now, could change tomorrow, but as of right now, it's not. That's the way they told us to do it. And then this is for services prior to March 1, 2020. If it occurred during 2020, the rate change was $13.53, and that's how much CMS would pay you for those virtual visits. That would only include those two different types of G0012 and the G2010 would be the only two bill types that you can, or the not bill types, the CPT codes that you'd be able to convert to a G0711 during that period of time. Almost finished here, but what do we need? We absolutely need another modifier to confuse things. And so on April the 7th, CMS announced that there's a CS modifier that relates to COVID-19 testing. And on this page, it's a little bit easier to read. And this doesn't just relate to telehealth services. This relates to any COVID-19 sort of E&M visit where you're trying to determine whether to test for COVID-19 or it results in a COVID-19 test. So let's look at what it says. Cost sharing does not apply for COVID-19 testing related services, which are medical visits that are furnished between March 18th. So there's another date we got to watch. March 18th and the end of the PHE that result in an order for or administration of a COVID-19 test, or are related to furnishing or administering such a test, or to the evaluation of an individual for purposes of determining the need for such a test. So the problem with that language is how broad or how narrow is that? Do you have to have the ICD-10 code on the claim that's talking about COVID-19, or if you just have an E&M service where you're basically having a conversation to rule out the need for a COVID-19, is that cost sharing CS modifier appropriate? And I'm not sure what the answer is to that at this point. I know a lot of people have asked that question, and I've really never heard a good answer about how broad or how narrow CMS considers that. So if you think it should be a CS modifier on there, you know, I would probably lean towards trying to put that on there, but that is something we really need to flesh out a little bit more. So let's go on here. This little table here will help us with this. When is this applicable? March 18th, 2020 through the end of the PHE. Where is it appropriate? It is appropriate for RHCs to use this. You can see that it's available in a ton of different provider locations. What is it? It eliminates the patient from having to pay the copay or the deductible amounts for services related to COVID-19. And the provider is paid at 100% of the rate versus 80%. So it's attractive to our providers as well. And then how is it done? You basically add the CS modifier along with the CG, and you can add it along with the CG modifier as well. If you're talking about a telehealth claim, you're not going to have to add the CG modifier after July 1, 2020. But if you want to use that CS modifier after July 1, 2020 for maybe an office visit, add the CG, add the CS modifier, that will work just fine. You may want to refile some of your claims that started on March 18, 2020 if you could have used a CS modifier. I believe somewhere where it says they're going to talk about reprocessing some claims, but so try to make sure you have that CS modifier on there. And here is a reference for where we got the information on the CS modifier. Okay, that's all of the Medicare Part A stuff. A lot of people do have some Part B claims, and I'm just going to very, very quickly go over this because it's very important. The rules changed, and they make a big difference in your payment. And we're going to go over that real quick. So if you're just Rural Health Clinic, you can stop the video now and not watch this last 2 or 3 minutes. Otherwise, if you guys do have some Medicare Part B claims that you work with, that's what we're talking about right now. This came out in the interim final rule that was dated March the 30th, and CMS explained it very well. So I'm just going to read it. I'm going to read this because it reads better than I can explain it. We are instructing physicians and practitioners who bill for Medicare telehealth services to report the place of service code that would have been reported had the service been furnished in person. And what this means is before, and let's go to the next page here because we got to before pre-COVID, February 28, 2020 and before, for telehealth, you would have been using place of service 02. Your payment would have been limited to the facility fee payment only. It's about 30% less than the non-facility payment. So let's go over here and do our time of PHE. During this time period, March 1, 2020 through the end of the PHE, you can now use, for example, if normally the service was provided in your office, then you're going to use place of service 11 and modifier 95. And then at that point, you'll be eligible for payment on the non-facility fee schedule. What's the difference there? We went through and looked at about the 10 most common, HCPT codes, the established office visits and the new office visits. We put in the amount from the place of service 11 using modifier 95 and place of service 02 using modifier 95. And you can see the difference in payment. We got over $1,000 for this particular bundle of services, and versus $743 for the place of service 02 bundle of services. Difference of $273 and a 27% difference. So there's basically close to a 30% difference in reimbursement for those codes. So you want to make sure that you do that. Some services are, we won't affect these at all. If you're doing services based out of the hospital, then you're not gonna be, this will not affect your payment rate that you received. And let's go through a quick example here. This is pre-COVID. The way this worked was you have a distant site provider in the big city, New York City. That specialist was going to get $53.33. They're going to use place of service 02, and they're going to use CPT code 99213. The patient, they're in rural upstate New York. They're gonna be looking at an RHC. That RHC is gonna bill as an originating site. They're gonna use revenue code 0780, and the HCPT code is gonna be Q3014. And Medicare is gonna pay them $26.15, and the trust fund is gonna in total pay out $79.48 for that particular service. Now, flash forward to during the PHE, there is not going to be an originating site. The patient can be in the home, they can be in an urban area, they can be anywhere, but there's not going to be an originating site because they're going to be doing it from their home. And Medicare is going to allow that Part B provider to bill using place of service 11, modifier 95, and they're going to bill CPT code 99213. In this case, they're going to get paid $76.15. And the total Medicare trust funds is going to be $76.15. Now, hospitals aren't really happy about getting a zero on the originating site piece, and CMS is actually looking at providing some type of originating site piece of money to them. But the key as of right now is place of service 02 could still be appropriate, but you really want to look close and make sure that if there's a way for you to use this place of service 11, modifier 95, that is going to be the way where you're going to get the most money for that. And then here are some of the modifiers that are typically used in telehealth billing. Number one is 95, and that they brought that one back out of the mothball, and they're using that during the PHE for telehealth. If you're a hospital and you're doing CAW method 2, there's a GT modifier that you need to use. Of course, the CS modifier, that's not only for telehealth billing, that's also for any type of billing that's related to COVID-19, where you're going to waive the copays and deductibles. If you're a part of a demonstration project for acute stroke, there's a GO modifier for that. And there's also a GY modifier for that deals with issues related to the ABNs. So those are some of the codes. CMS, if you see a GT modifier, CMS eliminated that effective January 1, 2018. So it's been a while since then. So I think that's everything. Hopefully this will not change too quickly because things are changing rapidly. Please watch all the different things. Please join our Facebook group, watch for our emails, our newsletters, and visit our COVID-19 website. We appreciate all that you guys are doing, and stay safe. Thank you very much.